Welcome to Patient Matters, where we dive deep into the world of plastic surgery. I'm your host, Dr. James Southwell Keeley. In this series, we will engage in candid conversations with patients, specialist doctors, nurses, and others who have shaped this journey. Together, we will explore the realities of plastic surgery, covering everything from safe practices and patient recovery stories to the latest techniques and the artistry behind the craft. We'll also discuss governing bodies, address botched and revision surgeries, as well as share simulated consultations, all aimed at guiding you through your own plastic surgery journey. With decades of experience, I'm proud to be a member of ASPS and the Royal Australasian College of Surgeons. I serve as a plastic surgeon at St Vincent's Hospital in Sydney. Join us as we unravel the complexities and beauty of plastic surgery, one episode at a time. Welcome and thank you for joining me. I'm your host, Dr. James Southwell Keeley. This is Patient Matters. Now, today's subject is skin cancer. It's a cancer of epidemic proportion in Australia. It carries the highest cancer burden in this country and in fact around the world. To help me discuss this, I've brought in an expert in the field and a dear friend of mine, Dr. Niamh O'Sullivan. I'll introduce you to her in a moment. Now, today's topic is Mohs, melanoma, and plastic surgery. There's a lot to cover, so why don't we dive right on in, and I'll introduce Dr. Niamh O'Sullivan. Niamh, welcome to Patient Matters.
Good morning, James. It's a pleasure to be here.
Niamh, why don't you tell me a bit about yourself?
Well, as you can probably hear from my accent and judge from my name, I grew up in the UK and my parents are both Irish, and I did my original medical school training over in the UK, did a PhD in Harvard in tissue engineering, and then moved over back to the UK to do some plastic surgery training. And following on from that, did my dermatology training in Western Australia, and then my Mohs surgical training here in Sydney.
Incredible. We'll dig into what Mohs is in a moment, but first, before you went to do your PhD in Harvard, you did a lot of surgical training. Were you thinking that that was the way your future would unfold?
That's a really interesting question. I think very early on, I saw a documentary, like as in my teens, about the boy David. So it's a boy that was born with a genetic condition and had craniofacial, so problems with his bones and his facial appearance, and the extensive surgeries that he underwent at the hands of these incredible plastic surgeons. And I was really kind of inspired by the before and afters and this incredible journey that somebody went upon, based upon their appearance and their altered appearance and how that would impact upon them in society. And so I pored over journals and I loved all the before and afters, and I kind of fell in love with the idea that you could change things dramatically and that could impact upon people's lives and their well-being. So initially I started off in the beginning going down a kind of plastic surgical track, and then I realized that the thing that I loved the most and that I felt was the most satisfying for me was kind of diagnosing and managing skin cancers, especially of the head and neck, and using the best evidence-based techniques to try and move that forward. And I still got the same satisfaction and the same creativity that I gleaned from my initial interest in plastic surgery. But the cancer focus was a huge kind of draw to me, and that kind of ability to both kind of impact upon lives, but also prioritize appearance.
Yeah, no, I think that's really important, and you can never underestimate that, really, because you change your clothing every day. You can get a different haircut. You step out the door every morning on the way to work to face the world, putting your best self forward, but it's always the same face.
That's right.
So it really has to be the best version of you to give you the confidence to interact with people, to get on with your daily life, to not be self-conscious.
100%. And I think that a lot of people will invest heavily in hairstyles and clothing and everything else, but really the best investment, in Australia that you can put in is investing in your skin and your skin health, because we know that that's the number one cancer threat to Australians, is skin cancer, and accounts for more cancer than every other type of cancer combined. So I think prioritizing skin health and well-being is just right at the top of the list, and is where our priorities should be in order to avoid longer term big surgeries or nasty diagnoses.
Yeah, 100%. I guess we need to touch upon both the prevention and the treatment, and really critically, the prevention and early diagnosis mitigates against the more extensive surgical treatments down the track. Look, we go back to the title, Mohs, melanoma and plastic surgery. We'll start with Mohs, but just before we do that, back in your bio you mentioned you did some tissue engineering at Harvard. Just tell me if this is right. Did you work in that lab where there was that incredible photo on the cover of Science or Nature or one of those massive publications with the ear growing in the back of the mouse? Did you work in that lab?
That is, well, I was in the adjacent lab in the same building. So that was Jay Vacanti's.
I'd call it the same lab.
It wasn't the Jay's. It wasn't the same lab.
I was like, it was separated by a ply wall.
We're literally, there's a plyboard wall.
Yeah.
I made a better ear. I made a human-sized, flexible ear, and they made a small, brittle ear. So I laminated it and made a flexible ear. So I improved upon it. But yeah, we shouldn't have this. Don't have this on the thing. God, sounds awful. Don't have this on the thing. This guy's a guru. No, I can't say it's the same. It's not the same.
Yeah, okay.
You know, but I worked in the same centre. So I was at Mass General Hospital, Harvard Medical School, plastic surgery research laboratory, and I made ears on the back of mice, and it was Time magazine.
Unbelievable.
Yeah, there you go.
Time, even better than Nature or Science.
Mine wasn't the time. Time was the other guys you were alluding to. Yeah.
So coming back then to Mohs, you and I know what Mohs is, but your average member of the general public doesn't know what Mohs is. So what is Mohs surgery?
So Mohs micrographic surgery was developed by a surgeon in Wisconsin and in the US in the 1930s. And it's a way of taking out the cancer cell, the cancer, layer by layer, until all of the roots are tracked and the entire cancer has been analysed. It differs to standard surgery because in standard surgery, you're looking at less than 1% of the surgical margin of a cancer. And then you're extrapolating that all the cancer has been removed. It's like looking at a putting green in an AFL stadium and checking every blade of grass and being happy that all the blades of grass are good, and then just saying that the rest of the stadium's good too. With Mohs, we're checking the entire stadium and underneath the seats as well. And I'm looking at the cancer under the microscope in real time on the day to look for those extensions of cancer. Because oftentimes skin cancers, it's not just what you see on the surface. They're like an iceberg or like an octopus in the surf. The tentacles are going in all different directions, and they need to be tracked. Because otherwise you run the risk of not taking out enough, which is a disaster. It means you have to go back and have extra surgery, or taking out too much. And we don't want to take out too much. So
particularly in those critical areas.
Oh, absolutely. I mean, the face is kind of, it's almost pretty much prime real estate. You want to conserve as much of the normal tissue as possible. You only want to take out the cancer cells. You don't want to take out the normal tissue. And Mohs offers the highest cure rates, up to 99% for like a primary cancer, so up to 99% cure rate, and the smallest scars. And that's what you want. You want to know that it's all gone. And then afterwards, for example, they go to you and we have a expert reconstruction on the same day, safe in the knowledge that all of the cancer is gone.
Coming back to your real estate analogy, because I think it's an excellent one, Mohs surgery on the back, is there a role for it versus Mohs surgery on the face? And on the face, are there areas that are better served with the Mohs technique and areas where it's not so critical?
Yeah, that's a really good question. And I think one of the things that's important with Mohs is the tissue conservation, right? Because we want to conserve the non-cancerous tissue. We want to keep the skin that isn't affected by the cancer because you may need that skin in the future, for example, to repair another skin cancer. So we've got to adopt a long-term view. When you're looking at areas like the back or the tummy or the upper arms or the thighs, Mohs is less critical because we've got more spare tissue in these areas. There's more pinchable tissue, so we're able to take a wider margin without compromising, on the aesthetics. If you're going to have a line scar anyway, it's not going to be a very
Doesn't
different.
matter if it's an extra half a centimetre inside.
Doesn't matter.
Yeah.
It's less important. However, if people have recurrent cancers that have previously been treated, say, for example, with freezing, with cream treatments, with light treatments, or with other surgery, and then they've come back, those recurrent cancers in even these off-face areas are very well served by Mohs, and especially if it's an aggressive subtype of basal cell. For example, infiltrative basal cell carcinoma, morphaic basal cell carcinoma, micronodular carcinoma. But also superficial basal cell carcinoma can be really overlooked, and it's often thought of as a lesser skin cancer, but we know that the studies have shown that they're every bit as difficult to clear as some of the more complex ones.
More aggressive ones.
Yeah, so that's really changed. So there is a role in areas off the face. Definitely the hands are very important to conserve tissue on the hands, the fingers, the nails. Below the knee, because it's far from the heart and it takes longer to heal in those areas, everything below the knee and the feet are really great for Mohs, because often it means that you can avoid a skin graft and you can have a primary closure, for example, which is a fantastic win, rather than having a skin graft which takes much longer to heal. And then there are special areas as well that we focus on, so sometimes genital or nipple areolar complex, these other areas where Mohs can be really, really useful.
I guess the common thread with all of those areas is that the skin is unique in that location. The lip is different to the nasal tip, is different to the eyelid, and they're all very well served with Mohs, the genitalia, or if it's not unique skin, there's a paucity of skin, so hands or feet, that sort of area. Plus or minus, you're in an area of porous circulation, so we're further from the heart. So the maximal preservation of skin actually makes a huge difference to a patient's recovery and the long-term result.
Yeah, huge, massive difference. I mean, in terms of, having cancers on the lower leg, and people often, you don't just have one. So you'll have one, and then it'll be inevitable that you'll get another. It's just when that is. So if you can keep every repair as small and as neat as possible, and every recovery as civilized as possible, so that you can get back in the pool earlier, so that you can go on your holiday,
get back into life.
It's just that's just critical. You can't really put a kind of a price on that, because that time is so
That's
precious.
right. So a skin graft recovery, for instance, might be 4 or 6 weeks before you're even just back doing your normal things, let alone being back in the pool. Whereas a straight line closure, if you can just sew up a wound, a surgical wound, you can get back into life much, much quicker.
Yeah, and I think that's really important, because if we accept, which I think we have to accept, that skin cancer is a part of everyday life and it's a threat that we all face going forward, doing the best technique early is so important, and making sure that we offer the highest cure rates and the smallest scars means that everything is just a lot more manageable and it can just fit into life. And then doing everything possible after surgery to go and look at risk and early detection and empowering. I'm very passionate about empowering my patients so that they understand what to watch out for and how they can best protect themselves.
So prevention is better than the treatment.
Oh, every time. Prevention is the key. It is absolutely critical.
I mean, it's human nature, and it's a function of the workplace in which we exist, that our first call to action with patients is a skin cancer, rather than you're not seeing a 20-year-old who comes in and says, I've never had a skin cancer. How can you help me prevent from developing one? And maybe in a generation or two's time, with ongoing education, that might change.
Yes.
I mean, that slip, slop, slap campaign from the 70s, 80s has made a big difference in terms of our use of sunscreen as a country. But you still see plenty of people sunbaking on the beach, and interestingly enough, they're often young people. They're late teens or tweens or young adults. Everyone loves the suntan. So I think that kind of message, it's a generational thing, and it takes a long time to really embed. But that's not really where we're seeing our patients, is it?
No.
We're seeing them with their sentinel event. Like they've been diagnosed, and then they might be 20, they might be 50, they might be 70, but you know that they're going to develop another one at some point. So yes, you try and reverse some of the problems that are leading to it, and manage that and rewind the damage that's already been done to the skin. But you've also got to be thinking, I've got to conserve the skin for your next surgery because I know you're almost certainly going to need another operation at some point.
Exactly. And you want to optimize the skin so that when, for example, we get the skin as good as possible, get rid of the precancerous change, have it as lovely and smooth and healthy as possible, and get you into some really good habits, then you find the cancers yourself. If there's a patient, you'll find the cancers yourself. You find it earlier. You call up, you come in earlier. We get things at an earlier stage. And what's wonderful is that you can avoid surgery. If we get things at the precancer stage, we can use creams, we can use lights, we can use all kinds of really important and really kind of cutting edge technologies to reduce the risk of you ever needing to have surgery. And I think that's right on there,
I think that's a key point. Surgery is often an end point, but it's not necessarily the only end point. And if your skin's well managed, then you can use these less aggressive treatments, but you've got to be very careful which patients you prescribe those treatments to. And unfortunately, we do see a lot of patients who've had way too many bouts of cream that is never going to work for that particular problem. And then they come with a much worse surgical dilemma than they would have had if they'd just bitten the bullet and come and seen you or me in the first instance.
Yeah, absolutely. And we've had a lot of combined cases. We deal with some of the most complex skin cancers in the country and probably the world, when we look at the burden that Australia faces. And I think sometimes one thing that really strikes me is that in an effort for people to avoid surgery, because it can just be so confronting and so terrifying, they shop around and try all of these different things under a range of different providers, and nothing's working. And the reason it's not working usually is because the cream's not right. It's the wrong light treatment. For example, you're using the wrong therapy and you're using it in the wrong way for the wrong cancer. And for example, maybe the lesion hasn't even been biopsied, so people don't even know what they're treating. It's a kind of blind treatment, or a kind of bathroom cabinet roulette where you're trying, your husband or your wife's cancer cream, and then you're polishing the surface. So things can
So the surface
better.
then looks better, but you
yeah.
haven't dealt with the roots.
And the roots are all still in there, and they're all still growing. So another name for basal cell cancer, we used to say when I was in plastic surgery training in the UK, was, a rodent ulcer. And the reason is this nasty cancer is they're eating away beneath the surface. And there's a wonderful video which just shows almost like this iceberg, that you can see this little thing. It might look like a nothing to you.
A pimple.
Yeah, a
or
pimple.
A mosquito bite.
Yeah, my patients every day say, I thought it was a blind pimple. I thought it was...
I scratched myself in the garden.
Yeah.
It was a rose thorn prick.
Yeah, spider bite. I thought it was a bit of dermatitis. I thought it was a bit of dry skin. I didn't think it was anything. And I think what is really
But
critical,
key in that repeat history that we always hear is it didn't heal.
It didn't heal.
Didn't get better.
Didn't heal. And so I say to all of my patients, after we've dealt with the surgery and we're talking about prevention, I teach them what to watch out for. And we say, if there is something, I don't care if you think it's a blind pimple or a scaly patch or something dry or something that's a bit scratchy or a bit sore, not healing or growing or bleeding easily in the shower, when you're toweling off if something's bleeding easily, these are all warning signs of a skin cancer. It might not look like much to you, but if it doesn't heal on the face within 4 weeks, you need to get an expert to look at it, and it may well need a biopsy because it is a skin cancer until proven otherwise.
I think that is a huge take-home message. Skin cancer until proven otherwise. What about the older skin? Oh, look at my skin. I'm Anglo-Celtic background, like yourself. And white for now, but fast forward 10, 20 years, I'll be covered in spots, blotches, variable pigmentation, scaly bits.
Yeah.
Can you rewind that and get it back to a more uniform, more youthful pigment tone so that it's easier to spot the problem areas when they arise?
Yes, you can. So there are a number of things that you can do something about. Probably the number one thing that we do is we kind of moisturize and basically descale the skin, because sometimes you literally can't see the wood for the trees. You can't find that cancer because all of the arms are, scaly, dry, wrinkles. You've got these different color patches, and it can be very, very difficult to find the cancer. I do a lot of treatments, and I have a huge focus on improving the quality of the skin to make it easier for both the patient and myself and any other physician they're interacting with to find a skin cancer. an analogy that I use for the patients is it's like looking for a golf ball in the rough, right? If you're looking for a golf ball and the golf ball is the cancer and you're looking in the rough, you can't find the ball. You could be in there hacking all day, you're not going to find it. If you're looking on the fairway, you've got a better chance. But if you get your skin to green style quality and you're looking for that golf ball on the green, unless you've been lucky and got a hole in one, you're going to find it straight away. You know, I've had two in my life. Yeah.
Gold.
Yeah,
Well,
yeah.
you've had two hole-in-ones.
Two hole-in-ones, yeah.
No.
Well, one was pitch and putt, it doesn't really count. But yeah.
That doesn't count at all. Off the tee, you've had a hole-in-one.
Yeah.
Oh my God.
Yeah, I know. It was a fluke. It was a fluke, James. It was a fluke. It'll never happen again. It'll never happen again. Yeah. But we want to look for a skin cancer on that pristine background because then anyone can spot it. It makes everything much easier. In terms of pigment, there are things we can do to help with the background pigment, but you've got to be so careful. And I've seen a lot of patients who've come to me because they were going, for example, to a cosmetic clinic or a laser clinic or they were going for a beauty treatment essentially to help with pigment.
Yeah.
And they were getting laser treatments and all these different fancy creams, spending thousands. Yeah. But actually, nobody was really examining their skin with a dermatoscope. They weren't going in and looking at what is this spot that I'm treating.
Yeah.
And so actually, they were getting the surface polished. And beneath them, we've done a lot of these cases actually, where the patients were regularly going for laser, for example, for pigment change, for rejuvenation, to look better, to look fresher, to look younger. But actually, a cancer was being, unbeknownst to the provider, treated or not treated, but polished over the top. And then people have ended up with huge surgical defects, big defects on the face, size of a tennis ball, because they were having laser without actually having a skin check first. And I think safety is paramount. And I say to all of my patients, I'm a cancer-focused dermatologist. That's my absolute passion. I'm not a cosmetic dermatologist. I'll help you with that, but it's always cancer first. It's cancer first, cosmetic second, and that is the absolute way it should be. And then when you're having the cosmetic work done, you have to have it done by somebody who knows what to watch out for, so that you're not accidentally having a skin cancer being altered, which may delay the diagnosis and can end up in you having much larger surgery than you ever needed to have, or having surgery at all. Because if it was found early by a good dermatologist, you may not even have to have surgery at all. So I think that's really important.
Some patients come to me and they say, I feel terrible. I've been seeing my GP for years. They've been looking at this patch and they just haven't acted upon it. And now I've got a cancer problem. And what I say to them, I'll be interested to hear what your thoughts are on this. What I say to them is that the skin cancer burden in this country is such that there are just not enough plastic surgeons, there are just not enough dermatologists to deal with the sheer volume of skin cancer. GPs are still your first port of call, and if you see a GP with a special interest in skin cancers, they can be fantastic. Now, they're not all amazing, and you definitely get a variety of different skill levels within that craft group. But they are still carrying the burden of this disease, of this management for this country. And I think my opinion is we have to respect that and we have to be there to help them and make that easy transition from this problem's now beyond my help. I can just send this patient to Neve or I can just send them to James. Yeah. And I certainly see lots of referrals from GPs where they've done the initial 2 or 3 skin cancer managements really exceptionally well, and they've just put their hand up and said, this one's beyond me, over to you guys. What do you think?
Look, I think that's really important. And we know the statistics are that, of course, without the GPs in Australia would really be in the strife. I mean, the majority of melanomas in Australia are cut out, by GPs, thankfully. And that's helping, that's helping hugely. Similarly, a lot of basal and squamous cell cancers are also dealt with in that sphere. And without them, we'd have a much higher death rate. We'd be dealing with a much more complex surgery. But I think what you've touched upon is really important, that there is a huge variety in skill sets. If you've got someone that you're really comfortable with, who you feel comfortable with, who you can get into as well, which is accessibility is really key, then I think that's really important. And I even do some shared care with some of my patients, and I'll see them every 6 months, and the GP will see them the other 6 months, and we can share the load to get 2 sets of eyes on the problem, which is really good as well. But I think there's a huge variation. I mean, dermatologists, we're the peak body for skin cancer and for all skin concerns in terms of our regulations and our exams, our rigorous exam processes. So if you're concerned, if you've got a history of skin cancer, I think really, it's a good idea to have a dermatologist who you feel comfortable with, who you can trust, and to be on their books as in addition to your GP, so that you've just got that kind of second set of eyes.
That's my attitude too. Yeah, you need a trusted dermatologist. You need your trusted GP, and if you've got a GP with an interest in skin cancer in the mix, that's great. You see your GP for your GP-related problems.
Yep.
You see that GP with a skin interest for routine checkups, but you also need to see your dermatologist. And then bouncing between those two for your skin health is probably optimal. You just can't see every patient that wants to see you. But if you share the care with that trusted GP, then that really is very helpful.
Absolutely. And I think one thing that's really important about having a dermatologist as part of your skin health kind of journey is that a lot of the time, people will have, you may also have eczema, you may also have dermatitis or psoriasis or acne or rosacea, which, as we know, is really common, especially in Anglo-Celtic skin types. You've got all these other skin conditions that can actually mimic skin cancer. So it can be really, really difficult, because you might have a dry patch, a pimple, a red spot, and you might have several of them, and maybe 4 of the 5 spots are just are a rash or maybe they're fine and they can be sorted out with a cream or a tablet or something different. But then one of those might be a skin cancer lurking in there. So the problem is sometimes if people are seeing people who are less specialized, is they may end up having maybe 10 biopsies where maybe they only needed 2. Yeah. And they've got a grumbling skin condition, be it seborrheic dermatitis or rosacea.
The flip side can also be true too, right? They've had no biopsy.
They've had no biopsy.
The whole thing's been treated as dermatitis and just prescribed a steroid ointment.
That's right. So you've got this kind of, you're hiding the cancer, or you're not knowing what was what. And I mean, as recently as yesterday, I saw a patient who'd had, cream treatments, which can sometimes be used for certain skin cancers, but it's very specific. Used on the leg, but they hadn't had biopsies prior. And they came to me saying, can you also check these? Are these okay? But of course, I had no idea what they looked like to begin with under the scope. I had no idea of the the exact regimen that was prescribed for them, and all the patient compliance was maybe variable.
What cream have they used for how long?
We don't know, and it's not a one size fits all. And everybody needs to be followed up. So I think, if anyone has had a treatment under another provider for a skin cancer and that skin has not gone back to normal, that needs to be reviewed, and it probably needs a biopsy to make sure that the cancer isn't still there. Because otherwise it can be growing beneath the surface. And you can end up needing big surgery, because maybe you were lulled into a false sense of security. Maybe the surface was polished, but the roots have kept going. Because the cream only works for certain cancers, and not every cream. There's Effudex, there's Aldara, there's these different brands, and they don't all work for everything. And if things have got deep roots, and if cancers are aggressive, or if cancers have come back and people have used a cream or a light treatment, that's a fail.
That's a fail. You can't use the same technology again.
No, you can't. It's like banging your head against a brick wall. If you've got this scarred tissue there, and then you're going back over the top of it, trying to use another technology, it's not going to get you anywhere. No. You're going to end up with a much bigger scar. And it's the same thing with, radiotherapy or these other modalities that we have, which can be excellent, but they need to be kind of used correctly. And if they're not, and if we're just doing everything in the toolbox to avoid surgery, what you end up having, which is really sad, is you end up having huge surgery.
Yeah, you end up having a much bigger operation.
Yeah. Which is avoidable, and that's a real pity, because that's entirely avoidable. You see the right person, you get the right treatment at the right time, and critically, if you attend your follow-up and have your own radar switched on, that's really important.
Which is easy when the skin has been rejuvenated, and it's easier to spot the problems. Now, you and I have pale skin. Majority of skin cancers in Australia and worldwide occur in paler skin individuals, but it also affects people with darker skin tones, even affects people with really, really dark skin tones. I mean, Bob Marley died from a melanoma, right?
Absolutely.
It was a subtype of melanoma. It was a specific type, but it's still a melanoma.
And I think that really blows a lot of my patients away, that they say, oh, I've got a tan, I'm fine.
Yeah,
Or like,
I've got Italian parentage, my parents Spanish, I've got Southeast Asian heritage, I've always this colour, I never burn, I'm never going to... It's not a protection.
It's not a protection, and all tan is damage. And I see a lot of families in my practice. So often I see like the whole family. And what I notice is people will get competitive about their skin types. They say, well, I always tan, and they're milky white, and they're the pasty one, but I tan, and I'm fine, and I can go to Bondi, and I can sunbake, and I'm safe because I'm tan. What we know is that all tan is damage, and you don't ever have to burn to put yourself at risk of a skin cancer. You actually just need a third of the amount of UV that would turn your skin red to cause damage to the DNA in the cells of your skin that would lead to a skin cancer. So you wouldn't even know, you wouldn't even have turned pink, but your risk is heading up. And I think, this concept that all tan is damage is a really difficult thing for us to try and reverse, because for so long, since Coco Chanel got accidentally sunburned, we've believed that a tan is beauty, and has been equated with beauty, and also in women, like in feeling slimmer. When I grew up, if you had a tan, you were more attractive, you were slimmer, you looked better. But then now we know that damage that's been done is difficult. And there's one of the things is the skin cancer risk, which is huge. You only need one blistering burn as a child to increase your risk of melanoma. Well, most people have had that, right? Almost everyone has had, especially in this environment.
Yeah.
But also in the UK with package holidays to Spain and to France. People similarly had a burn as a child where they remember peeling off their nose. That's enough to increase your risk of melanoma. What else matters? I did a paper a couple of years ago on the risk of tanning beds and cutaneous malignancies, so skin cancers and tanning beds and nail lamps, and what the risk was. And that was published in the Australasian College of Dermatology journal. And what was really interesting about that is we learnt that only having once in your life used a tanning bed, ever used, they call it, so once only, increases your risk of melanoma.
Wow.
And that's huge.
Yeah, like the blistering sunburn.
Like the blistering sunburn, and the family. Of course, we've got genetics too, you know, and if there's a family history,
of course.
You've really got to look at you with a fine-tooth comb.
So we've sort of pivoted now towards melanoma, which is a natural transition to the next part of our discussion. Now, is melanoma the deadliest skin cancer?
That's a really good question. Traditionally, it has been. 20 years ago, there were no treatments for melanoma, and if you had a nasty melanoma diagnosis, we had surgery, and if surgery didn't work, there was nothing.
Yeah.
Now, in this, it sounds like a funny thing to say, but when I'm telling my melanoma patients, there's almost never been a better time to have melanoma, because now, we've got amazing immunotherapy. It doesn't work for everyone.
Yeah.
But there's been incredible advances, which mean that people can live for years who would never have had a chance before the advent of immunotherapy. And that's something, fantastic. I saw some amazing cases when I was in Western Australia, and then when I moved to the Melanoma Institute, I saw incredible stories of people who had cancers which would almost certainly have been a death sentence.
Sometimes you were given a 6-week...
Oh, yeah, exactly.
6 weeks to live with your diagnosis.
6 weeks to live, and if you had 6 months, that was, that was amazing. That was unbelievable. And now we've got people who live for years. But what's important is that there's nothing better than prevention, because those immunotherapies, it doesn't work for everybody.
Yeah.
And the side effects can be really debilitating.
Yeah.
It basically switches on your immune system to attack the cancer, but it can also turn your immune system on your own organs. And some people can't tolerate it. They can't continue with it. And these treatments don't work for everybody.
Yeah.
So prevention is just the number one thing. Back to what you were asking about.
Prevention and then early detection.
Prevention and early detection is just key. But when you talked about and asked about, is melanoma the most deadly? It's the one that everyone's afraid of. We've all known people, we've all lost patients and friends and family to melanoma, and it really is, it's the one everyone's afraid of. But actually, really interestingly, last year there was a paper that showed that squamous cell, or some of my patients say squamous cell cancer, SCC, has actually overtaken melanoma in terms of death rates globally. This is because it's the second most common skin cancer. So this basal cell is the most common, squamous cell is the second most common, melanoma is the third.
Yeah.
But the treatments when they get advanced, the treatments just aren't there yet. So
for the squamous
for
cell.
the squamous cell, they're working on it.
So we've got surgery as a mainstay. Mm-hmm. Your backup is radiotherapy.
Yeah.
And sometimes that's combined with the surgery.
That's right.
If they've failed, if it's come back,
Yeah.
the chemotherapy options are rubbish.
They've got some immunotherapy
And the
that's coming in.
immunotherapy, it's still in its early phases.
It's in its early phases, and it can work for like super advanced cases. But again,
But with your stage 4 squamous cell versus a stage 4 melanoma, you'll have much better treatment. You're much more likely to have treatment success with the melanoma than with the squamous cell.
And more trials, more funding, more awareness. And I think one of the problems, that we have with the skin cancer is often they're underestimated, and people think, oh, it's not a melanoma, therefore it's not important. I hear every day, and this will be in your practice too. It's only a BCC. It's only a basal cell, and people think it's not. They think, but it's not a cancer. It's not important.
Yeah.
We can never underestimate these cancers, and we really have to respect them, because you can lose a significant proportion of your face.
Yeah,
you can
that's
lose
right.
We've seen people lose their eyelids. We've seen people lose their eyes. We've seen people lose their entire nose. We've seen these cancers track through
the nerves and into the brain.
Into the brain.
Yeah,
we've seen.
So the basal cell typically, and obviously not for you, but for our listeners, doesn't spread to distant sites, although it can in very rare circumstances. It spreads by direct burrowing. And if it invades a nerve, it's like turning off a busy traffic city road onto a freeway, and then it travels very quickly. But the squamous cell can travel, and it travels through the lymphatic. So it can end up in glands in the neck or in the armpit, depending on where the cancer was, and then seed the body from there. Melanoma, interestingly, can travel through the lymphatics, but also through the blood.
Exactly. Really interesting. And melanoma's got 2 superhighways through which it can travel. One of the most important things with melanoma is you want to get it as early as possible. If you get surface disease, I think of the skin, in a very basic level, it's almost like layers of a cake. If you've got it when it's icing on the cake, which is the epidermis, the top layer of the skin, that cancer is much safer because there's no roots. Melanoma and the risk of melanoma traditionally has been thought of as being dependent upon how deep the melanoma is. It's called the Breslow thickness. The earlier we can find things, and if we can get an early evolving melanoma or melanoma in situ, surface melanomas, then you're much less at risk of them threatening your life down the line. They tend to grow much slower. Something really interesting about the squamous cell cancers is they can come up overnight. So you can have nothing, and then you can develop what I say to my patients: a painful scaly volcano can just pop up overnight. And that's very worrying. They grow very fast.
Yeah.
If people have got fast-growing things like that, your feet shouldn't touch the ground. You need to be making a call, getting that checked immediately, because they can double in size in a week, in 2 weeks, and then they really need to be dealt with very expeditiously. That's very important.
Before we leave melanoma as a topic, because it's a huge topic in and of itself, but I think for the general public, the key is be aware, be alert, don't be afraid, but get stuff checked. Don't put it off till next year. Don't put it off till after your holiday mid-year. Just get it checked and have the skin looked at by someone who knows what they're looking at. What about Merkel cell carcinoma? That's a different sort of skin cancer, isn't it?
It is. Merkel cell carcinoma is a different type of skin cancer, and it's actually got horrendous. It's also got a horrendous prognosis potential.
Probably even deadlier.
It is actually more deadly than melanoma. Yeah, it is. It's more deadly than
much,
melanoma.
much rarer.
And much, much rarer. And it can look identical to a squamous cell carcinoma. I had a BCC. Or right? A BCC. I had a recent case on the chin. It looked like a pimple. Had come up very quickly in about 2 to 3 weeks. And we biopsied it, and it was a very advanced Merkel cell carcinoma. Of course, I had to send the patient off for scanning, whole body scanning, sent them off in the end to some specialist, to a specialist head and neck surgeon, because they needed to potentially be able to remove the lymph nodes in the neck. Yeah. But the prognosis is very grave. Yeah. And I think we have to be, and the only way really that you can get on top of that is just by fronting up as a patient as early as possible. If you have a lump or a bump or anything that you don't recognize on your skin, you can't take a chance. And if you put your head in the sand, you'll really end up in trouble. But just fronting up and Also believing your gut is very important for the patients too, because a lot of my patients, they'll see someone will say, oh, it's probably nothing, it's okay, it's probably nothing.
Try this cream, see you in 12 months.
Yeah, and I say to my patients, if you can't sleep, right, if you can't sleep, if you're going back, if it's gnawing away at you on the inside, or if your partner's on at you, just ring back up again and say, look, I'm not comfortable with this, I'm worried.
Get a second opinion.
Get a second opinion, just make sure that you get to the bottom of it, because there may be roots there and you need to find that root cause so that you can treat it and you can just move on with your life.
Yeah.
But if you're afraid, that fear can actually, that can be very dangerous.
Yeah.
Yeah.
And look, I think you touched upon this indirectly. We as medical practitioners like to think that we don't make mistakes, but we're human. We all make mistakes. And if you think that your skin healthcare provider has made a mistake, has misdiagnosed something, don't sleep on that. No. Get that second opinion, or go back to them and say, I'm really not happy. Can I please have a biopsy? Or refer me on to someone who can do that for me.
Yeah, 100%. I mean, I think it's not about pride, is it? We all take, I think we know as a patient and as a person, we know our own bodies, right? And if something's not right, if it's not sitting with you right, we've got our gut, and the gut instinct is very powerful. So for melanoma, we say we look at the A, B, C, D, E's. We're looking at asymmetry, we're looking at border, we're looking at the color of the lesion, we're looking at the diameter of the lesion, we're looking at whether or not it's evolving. Have we got a mole that's changing or itching or bleeding? And to that, I add like F and G. Like F is for feeling and G is for gut. And then there's U for ugly duckling. So the ugly duckling is ugly duckling is like
that.
Yeah.
You've expanded my acronym.
Yeah, this is it. So there's the ugly duckling is like the one spot on your body that's just drawing your eye. It's this or maybe it's on you, maybe it's on your partner.
Maybe no one else's eye has been drawn to it. But if you just can't get past that thing on your calf.
Exactly.
Don't get past it.
Don't get past it.
Get it looked at.
Get it checked, because we've got a survival instinct, and you don't need to know what's wrong. You don't need to know what the problem is. You don't need to be able to describe it. You don't need to go on Google or anything else. If you're thinking, I don't like this and I don't know why, or I'm looking in the mirror, just keep looking at it.
Yeah.
There's probably something in you that's trying to alert you. There's a survival instinct, and you get that checked. If you still can't sleep, you get a second opinion. But, make sure a biopsy is gold. Biopsy is the gold standard. If it's been seen under the microscope and assessed by somebody who knows what they're doing, like a really great dermatopathologist, has looked at it under the microscope. And I look at a lot of the slides myself as well. What exactly is this? What does the skin look like under the microscope? Is this dangerous? Essentially, is this friend or foe?
Yeah.
And then you can relax. If you know that it's been tested under the microscope, maybe you'll have like a small scar from the biopsy. It's a small price to pay for a huge peace of mind.
Yeah.
And if it is something and you've got it early, you're way ahead of the game.
Correct.
And you're going to be able to avoid something much bigger than if you just left it.
I'll add something to your biopsy comment, because I think your gut then as a practitioner sometimes says, I've taken the biopsy to alleviate the patient's concerns. And I was a bit worried too. I've looked at the biopsy now, and the biopsy says there's nothing to worry about. This is not a skin cancer, but something's still not right for me. I will sometimes recommend to the patient, we need to remove the whole thing.
Yeah.
Because the biopsy is just a small piece of the lesion. If it's in a very tricky area, if it's your whole cheek or something like that, well, it's not practical. But if it's on a leg or a thigh or a back, and maybe you're just not comfortable, I take the whole thing. Say, okay, we'll have the rest of it. And now to my pathologist, please have a look at this and tell me that there's nothing there. Because the biopsy, sometimes you get a false reassurance that there was nothing there. Yeah. Whereas, there's obviously something there. And there's lots of different reasons for that.
Absolutely, and I think that happens all the time. Clinico-pathological correlation is our big word for it. But essentially what it means is, what are we seeing as a doctor, and then what are they... And it'd be a dermatologist or a plastic surgeon, and then what is the pathologist seeing underneath the microscope? And is that making sense? Does it fit? It's like a jigsaw.
And it's like a telephone call sometimes, or a photo. Send the photo to the dermatopathologist and say, this is what it looks like.
Exactly.
This is what it looked like on week 1. This is what it looks like now, a month later.
Yes.
And this is the story. What do you think?
Yeah. If it doesn't make sense, the whole thing needs to come out, because... Again, a biopsy isn't necessarily representative. And as you said, if you've got a large area, for example, a large area on the face, you can't biopsy the whole area. You can't do it. So you have to, I use, for example, a dermatoscope, which is a 10 times magnification polarized light. I'm really carefully analyzing the area to try and see if I can pick the most abnormal area to biopsy. So I can do kind of bespoke biopsies in the most worrisome areas, but still that's not 100%. We might just be looking at, again, to use another golf analogy, we might be looking at the green in the context of the hole. It's not telling the whole story. We're just getting a partial story.
Yeah.
And I think if it's not making sense, it also depends upon the patient's risk profile, because maybe you've got a really high family risk of melanoma. Maybe you've had a lot of skin cancers yourself. What is your risk profile? And it's all got to be taken in context. Yeah. It's not one size fits all.
And if it's a 3 millimetre biopsy scar versus a 10 millimetre excision biopsy scar, it's only 7 mil the difference.
Yeah.
And if it's done nicely and discreetly, that's much more peace of mind, ultimate peace of mind.
Ultimate peace of mind. I mean, I think if the whole lesion is analysed, that's great. And sometimes I use some advanced imaging techniques to help when I've got larger pigmented lesions, for example, on the face. And they can be helpful to help us, again, to identify...
Confocal?
Yeah, the confocal microscopy. I refer some people for that, for large facial pigmented lesions, just to try and see if we can see any worrisome cells beneath the surface and try and see if we can target biopsies like with that.
Yeah. So how does that differ from standard dermatoscopy?
Yeah, it's so it's using a kind of high-powered laser to produce a black and white image of the cells, like just at the very surface of the skin. So it doesn't go very deep, either does my dermoscopy, but it just shows a very different image. It's a highly specialized technique, and it very much varies upon who's doing it and who's interpreting it.
Yeah.
And
an evolving imaging modality.
It
an
is.
Evolving technology.
It's an evolving technology.
But
it's
we're
not
at the forefront, really, aren't we?
Yeah, we're at
in
the
this
forefront.
country.
Oh, 100% we're at the forefront. And I think it's useful, but it's not an instead of. It can help. It can help to guide things. It can help to map things.
It often helps find the margin, doesn't it?
Yeah, it can help to find the margins.
It sees beneath the surface.
It can help to define the margins of things that are poorly defined. But I'm very specific about who I refer for that. So it's not a one size fits all, and nothing is. So you've got to be quite careful about what you use it for, I think. And it's certainly not a treatment. So that's the important thing. There isn't a non-invasive treatment. So it isn't. Some of my patients ask me, "Can I have this instead of surgery?" It's like, no, it's just to help decide that where the margins might be. It can be helpful with that, or to try and find in a very large lesion where are the more worrisome spots. I don't find there's much difference between what I can see under my scope and what they can find a lot of the time. But in somewhere it's super subtle at the edge, it can be really helpful.
Yeah.
And it saves us having to go back for multiple
scary,
surgery. Absolutely.
When you look at it macroscopically, the patient at the bedside, and you say, okay, well, that's where I think the edge is. Use a marking pen, surgical marking pen, and just dot out the edges. And then you often have a little a diagram or a transparent piece of plastic that the image has been marked upon by the confocal microscopist, and you transpose it over what you thought, and you think, wow, that's quite a lot bigger.
Yeah, it's really interesting. But we are so lucky in Australia to have, we have got the best of technology. So it is unfortunately we have the highest skin cancer rates in the world, but thankfully, we've got some fantastic people.
The expertise that goes with that.
We've got the expertise, yeah.
Now, loaded question. Part of that expertise formula is plastic surgery.
Yes.
Where does plastic surgery fit in your algorithm for the management of skin cancers?
Plastic surgery is really important, I think, for the management of skin cancers, especially when we're dealing with, obviously at our level, we're dealing with a lot of complex skin cancers of the head and neck. We've got patients who've got skin cancers on eyelids, on noses, on lips, like in the central face, and affecting the ears. And even like critical areas like the chest, really important areas that can potentially scar very badly. I think it's really important to do kind of joint cases and to use the best of both of our expertise. I'm taking out the cancer layer by layer to get the highest cure rate and the smallest scar, making sure that all the tentacles and the roots have been taken. But then I want to use, for example, your expertise as a plastic surgeon to help to reconstruct both the form and the function, and to hide the scars in the natural expression lines of the patient's, the patient's face, to give them the best possible scar outcomes. And I think something that's really great about working together is that you do a lot of amazing kind of high quality aesthetic work as well. So facelifts, blepharoplasty, all these different aesthetic operations to help people to feel better, to look better, and all of those skills that have been honed over the years in doing that, and that huge understanding of facial anatomy is so critical to giving patients the best possible scars in these really tricky cases where, for example, we have to move skin from A to B, and we have to, for example, reconstruct an eyelid or an ear and make a new ear, or, reconstruct a lip where we don't have much spare tissue. So I think that expertise and that understanding is very important. And I think somebody who does, if you can do high quality facelifts and all these fantastic aesthetic work, those transferable skills, that really neat, that fine stitching, that all comes into play and can reconstruct like the defects left by the cancer really beautifully, giving patients, young and old, like a lot more confidence in their appearance after having what can be a very disfiguring skin cancer.
Yeah, absolutely.
So it's a very complementary skill set, and it's super important.
And very complimentary word, so thank you.
Oh, no, not at all. All entirely.
So let's walk through a patient's journey then. They come to see you. They've often come from a GP or from another dermatologist, because not every dermatologist does the Mohs surgery.
No.
So you'll often have a patient who's had something picked by the GP, sent off to a dermatologist. The dermatologist says, I don't like the look of that. They may or may not have biopsied it. It's in a tricky area. It's on the nose or on the lip. And they think, you know what, maximal preservation of non-cancer affected tissue is of paramount importance in this case. I'm going to refer you to a Mohs surgery colleague like yourself. So they're off to see Neve. And then you look at it and say, okay, I think your case will be best managed in conjunction with James. And so you refer the patient on to me.
Correct.
We communicate. You send me beautiful diagrams and photographs with the patient's consent about what we're looking at. Because sometimes I look at it and I think, where is this thing? Maybe it's a tiny little healing biopsy scar. But we piece together the puzzle with the information that we have, and then we come together on the day of surgery.
That's right.
And you do the resection and looking at the specimen as it's removed real time under the microscope, layer by layer, making sure it's all removed, but we maximally preserve what's critical, what's unique, be it the lip or the eyelid or the ear. And then I'll come and meet the patient afterwards, and I'll either have a look at a photo that you've taken with the patient's consent intraoperatively, because I have a dressing on at that time, or I'll take the dressing down and reassess what I thought I would be looking at compared to what I'm actually looking at. So the imagined defect based on the putting together of the puzzle before surgery compared to the true defect on the day of surgery.
Yeah.
And then it's all about putting the patient together as close to the way they were beforehand.
Exactly. Yeah, no, that's exactly it. I mean, that's the process, and then it's just about our follow-up then afterwards as well. I mean, if we do joint cases, then, you look after the scar care, then I'll look after basically prevention and early detection, and just doing loads of education to empower people going forward to make sure that we minimize the risk, because that's the thing. And if you've had one skin cancer, it's pretty much inevitable that you're going to have another. It's not if, but when. But what we want to do is we want to get the skin as good as possible, and we want to push that next one as far into the future as we can. Ideally, eliminate it. We're not quite there yet from a science point of view. Unfortunately, we can't switch a light switch and get rid of your risk profile.
Yeah.
But what we can do is we can minimize your risk. But I think we work very collaboratively, and I think something that a lot of the patients ask me about the Mohs, and they say, well, how big is it going to be, or what kind of repair am I going to have? And then before they see you, I'll give them an idea of like, well, this is what you might have. But one of the interesting things about Mohs is that we don't know the size or the shape of the defect. We can't possibly know, and there's no scan. Doesn't matter how fancy or there's no scan in the world currently that's able to tell you the size or the shape of that defect. The best thing is just underneath the microscope, and so that will dictate the size and shape. It could go north, south, east, west, deep. We just don't know. And then I suppose back to you as a plastic surgeon, your creativity and your ability to move around the skin to fill that hole, that is absolutely crucial, to get this right, because we don't know what it's going to look like. And some of the repairs, will be more simple. There'll be in areas that'll be easier to bring together. And it's such a win. If we can get a line scar, that's just such a win, you know?
Yeah.
Keeping everything small, keeping it tidy, because then you've got more skin for the future. So if you get something bigger in the future, there's more that we can move around.
Yeah.
Because there's only so much laxity that we have.
There's only so much real estate.
There's only so much real estate,
Yeah.
you know, that's very, you know, it's very serious. It's prime, and we just can't kind of negotiate on more, because bringing things in from other areas, doing different types of repairs, they won't look as good.
Yeah.
So I think some people think that, you know, Moses, the Rolls Royce or overkill or something that you didn't need. But you need your facial skin tissue. It's so critical. It's so important. Doing it for small things and getting them early and having a tiny line scar rather than having a great big flap or a great big graft that you didn't need after everything else had failed. I mean, we've had patients, James, and you know, they've lost their noses. You know, they've lost their nose, half their nose. They've lost their ears, and you just think if we'd have managed to, if we'd met them earlier, if only like there'd been more awareness and they'd gone in earlier, they would have so much more. Like they'd have better outcomes, smaller surgery, better outcomes, and just be like way more empowered going forward.
No, absolutely. I think some of those more complicated cases, and using the nose as an example, particularly the nose, in fact, often takes several operations to get that final result looking and functioning as well as it should. So that is definitely a discussion I have with patients, that the day of your Mohs resection and my reconstruction might just be the first surgical step towards the final outcome. Using the nose once again as an example, it's a trilaminar structure. So the more layers you've had to peel away in removing the cancer, the more layers I need to put back together, and the more complicated it becomes. So the inner lining of the nose sometimes needs to be replaced, the cartilage layer in between, or the bony layer, depending on how high or low we are on the nose, cartilage towards the tip and bone up near the top with your glasses set. And then the skin on the outside. So you can only do so much in one operation. And if you try and do too much, then it all falls apart. So just educating the patient that, okay, this is the first step. It'll be very confronting afterwards. We'll get through this together. You'll have plenty of support. And then the next stage will be in so many weeks, and then the final stage will be so many weeks after that, or whatever the case may be.
Exactly. And I think and scar healing as well is the same. We have, you know, these things are it's a process, isn't it? You know, your scar at 1 week is not your final scar. You know, it's a 12 to 18 month journey. And I think the same thing with these more complex reconstructions that you're talking about. Like, for example, if we do joint cases and you use the forehead to reconstruct or rebuild a nose, it's a surgical journey over months, and the healing journey, you know, over years. And also, you know, there's an emotional journey too that it's really important that you get great support with. And we're part of that network, and a great GP is part of that network. And, you know, family and friends support as well is so important, because it's not, you know, our face is so important. We see it every day in the mirror. We take it for granted. And when we have something on it, you know, it can be very confronting, and it can be a process of adjustment. But you know, but we know, like in our experience, you know, it comes good, but it's usually worse before it gets better. And I think that's something that you have to.
And sometimes you need to engage the services of a trusted psychologist to help with that adjustment.
Yeah.
And you and I have seen many patients go through that journey, and we almost have foresight, and we can see that this is all going to work out just fine. But for the poor patient sitting on the other side of our consulting desk, they just can't imagine life being anywhere near normal ever again when they look in the mirror in the morning, and they have to look at that every morning. And I can think of a handful of patients who, you know, there's floods of tears at the 1 week follow-up and more tears at the 4 or 6 week follow-up point. And then, you know, I'll sometimes refer those patients off for psychological counselling. But we'll always be there for them. The door's always open for them. And a combination of seeing them more frequently and getting that additional help with the adjustment. Meanwhile, all the time, the biology of healing is progressing and working towards a final nice outcome.
Yeah.
And so I think that it just naturally, they all get there in the end, and we help them to get there in the end. But I do tell patients, with those trickier reconstructions, look, sometimes we'll do a revision operation at 12 or 18 months. Because all the swelling's settled, everything's stopped moving. When it's swollen, it puffs up here and it comes down. And if you jump in too early, the board's still moving, and when you've made your adjustment and then it finishes moving, that was the wrong adjustment to have made. So sometimes it's better to sit on your hands and just let nature take its course and provide all of that emotional support you can. And then at the end, you didn't say, okay, now it's stable, it's settled, let's work on, these are the only two problem areas left.
Exactly. I think that kind of time is really important, like a trial of time, allowing everything to settle down. Everyone heals differently. And we have scars, I think scars in the week, where, part of the scar is on the eyelid skin, the other scar is on the cheek skin. We've got different qualities of skins abutting each other. So one area will be more puffy, or the lower end of the scar will be fuller, just because of sheer gravity.
Where it is, yeah,
gravity and the type of skin. And things will heal different in different places, and it'll heal better, and it might heal differently in the hairline, for example, than on the area in the skin. It'll be more noticeable.
Yeah.
But over time, we've got to, we focus on techniques to help with the scarring, to settle down. And there's a number of things that you can do, but also, good old-fashioned time is really important. And unfortunately, there's no such thing as invisible mending. We do our best to try and hide the scars and the natural expression lines of the face. The older you are, the easier it is to find more laughter lines and things to hide the scars in. But also, there is, it's a process, and you've got to kind of hang in there. But there are great, there are different things we can do. We can do silicone gels, we can do silicone dressings. Patients can have, for example, laser. And there's really good as well, like camouflage makeup, tinted zinc, so many different things that we can discuss
As simple as
afterwards.
massage.
As simple as massage.
Yeah,
Massage,
make a big difference.
Huge. Massage makes a huge difference. And massage, and also just in the very early stages when things are red. There's great makeups. There's great makeup that we can use. And, I've got a lot of my male patients, they're on this great tinted zinc, and we're using it like a concealer, and we're just, we're applying it to hide these scars. And the quality of the camouflage makeups, for example, used in Hollywood, that can hide a whole tattoo on an actor for a role. You can employ these too to help in those early stages, to help with confidence and the patient as well, like having some control over appearance for events and things.
And even the sort of rough and tumble chaps that we deal with, that you'd never imagine they'd have a problem with a facial scar, which in time will be very difficult to see. Yeah. In the short term, it might be raised, it might be lumpy, it might be red.
Yeah.
They can really get pretty wobbly in terms of how they're coping.
Yeah, I think it's just very, I think it's confronting for people, and I think a lot of people are asking you. I think if you've got a scar, for example, on your face, everyone's asking you. You're in the pub, you're in Woolies, and people are like, what's this? What's happened to you? Yeah. And I think people then feel very vulnerable. So I think, making sure that, I think it's not necessarily
those
a scar.
tools,
it's
not just to manage it, but also to conceal it, which helps with that psychological adjustment.
Definitely. So you've got to get your your story. So a lot of my patients then use their scars as a way to educate other people and to spread the word about getting checked, which I think is incredible, and it's very satisfying.
Well, it kind of completes the loop, really, in a way, isn't it? And the best advertisement for how important it is to be checked regularly is a story from a patient who's been through it all.
Yeah.
And then taking that holistic model to patient care and really looking after every aspect of that patient care journey, then puts them in a position to better educate their friends and colleagues and partners and family.
Definitely. I've got many patients who've now become the advocate in their workplace, or have started an initiative where they're doing a sponsored walk and everybody's wearing a hat, or they're doing or they're giving presentations about let's get a check and let's get a proper check early because this is what happened to me. And I think that's just tremendous because it's so powerful, because I think sometimes it's easy to think it's never going to happen to you, but if it's your colleague on the next desk, if it's your mother, your father, someone you're playing golf with, I think it's just much more real, because I think we think it's never going to happen to us until it does. And I think that's really, it's very powerful when patients are sharing their own stories. I think it's incredible getting the word out there.
Yeah.
Because that's really kind of getting the momentum for people to get checked. And this time of year, everybody's, the peeling off the outer layers, heading to the beach. I think it's very important just to kind of get the message out there again that it's time to get checked. And if you're Australian, you need to check really every year to make sure that there is nothing. I recommend an annual skin check for all of my patients, and just to stick to it, because when I see cases that are more advanced, it's just, especially during COVID, so many people just fell off the wagon. They just didn't go for their check for, maybe it was a year, then it was a year and a half, then it was 2 years, and now like some people are actually haven't had a check in 4 years. What we're finding, the fallout is that things are way more advanced. I'm seeing some of these cancers, these more aggressive cancers that I haven't seen for years, because they've just been like left, they've left,
kick that can down the road.
Yeah,
and life gets in the way, and other things take priority, and it's kind of the last thing you really want to do.
Yes,
particularly at a busy time of the year like this.
Of course.
But if you haven't done it before the end of the year, you need to tell yourself, well, before Easter,
exactly,
as the year gets wound up for 2025, I'm going to book in and do that check.
100%. You've just got to do it, because if you do it and you regularly go, you're just so much likely, you're so much better off to have a better outcome. You're just going to find things early, you're going to get on top of it. And
even 20-year-olds. I've had to remove nasty early stage melanomas from 22 and 20-year-olds in the last week or two.
I mean, James, you only need one blistering burn as a child, and that's the thing. And as I said, like it's so, you've got to really, like, people have got to protect their children like as much as possible. But we're seeing that there's all these trends again in tanning, which is terrible on social media. Yeah. There's people are showcasing pictures of like sunburn, with patterns on them, and I think it's really dangerous. That unfortunately, like tanning's kind of almost coming back into vogue, which is just so soul destroying. And as a dermatologist, I want a loudspeaker to go down to Bondi and just tell people to get off the beach.
Be stoned alive.
Yeah, you would be.
I'll talk you down from that one.
I'm not going to risk it. But I think another thing,
soft message.
Yeah, I think look, I think it's,
but it's
you
important.
Can't do that.
But
I think
it's so important.
I think that sometimes as well, things like these shades, and that again, like it's another thing, the shades at the beach, as another people say, one of the dangers of things like that, which obviously is better than no shade, is that you can be given a false sense of security, right? Yeah. So you can go in there, you can be underneath your shade, you think everything's good, you're going to stay out way longer than you would otherwise.
You might not be topping up sunscreen, and then there's all the incidental sunlight, and you're in and out of the water. Yeah. Who's topping up?
No one's topping up, because the thing is, I think what we realise is that none of the modalities to protect your skin on their own are enough, right? Yeah. So sunscreen on its own, it's not enough. You can't put your sunscreen on and then just go and lie out and be safe. It doesn't work like that. The covering up is very good. Avoiding peak UV is very good. Everyone needs to wear sunglasses, and the hats are very important. But I show my patients the pictures, of the professional golfers, who've got the baseball cap on. They take the baseball cap off, and they've got this kind of, porcelain white forehead, and they've got this kind of mahogany face and ears and neck. And it's really, it's really astounding, but it's a really extreme example. But it just shows you that there was a really good Swiss study a couple of years ago that shows you how 80% of the UV is coming at you laterally. So your hat is protecting the areas it's directly covering. You're going to have a younger looking forehead, your scalp will be safe. But if your ears are out, and if your face is out, your nose is out, and your lips are out, you're copping it all day.
Especially near the water. You're getting it reflected up as well as from...
Yeah, and with the sand, as well. So I think we've got to be careful. It's doing all of the right things together. And that's a really important part of the education that we offer after people have had these skin cancers, about, well, how can you get this right? And there are so many myths that have to be dispelled, because there's information coming from everywhere, but some of it's just very variable, and it's not based upon in science or fact.
Science-based, absolutely.
And it's dangerous, because you can be led down into a false sense of security and think that you're safe when you're not safe, or you can put on a tiny amount of sunscreen, some famous actors have been putting on a tiny amount of sunscreen, for example, onto the nose. It's a homeopathic amount. It's not going to save anybody. It's not going to make any difference. So it's about using the right thing, for the right purpose. Appropriate dose.
Appropriate area.
Yeah, and when you're putting it on. So there's many things about it. It's way more complicated than it seems. But once you know what to do, it's easy to get it right and reduce your risk.
Once you've got into the routine, it's easy to maintain, for sure.
Yeah. And then you look younger, which is amazing. So the best thing about doing all the right things for skin cancer risk reduction and that can be like everything I do, the field cancerization treatments, all these other things. I say, look, I'm not a cosmetic dermatologist, but after we've done all of this, your skin's going to be like newborn baby skin. You're going to have lovely skin, and you're actually going to look younger. And a bit of rejuvenation is a wonderful side effect. Everybody's happy with that. And you talk about, some of our patients, for example, some of the chaps I look after, that they wouldn't care about the way that they look, but once their skin has been turned around, they've got the best skin on the golf course, and their wives are saying, oh, hang on a minute, you can't have better skin than me. So I think that's amazing, because then it's like tidying the house. When the house is tidy, you don't want to mess it up, and it's the same thing. When you've got your skin in really good shape and it's smooth and it's soft and it's clear, you don't want to damage it. So you get better at your prevention, and then you're more in control, which is also an amazing, amazing endpoint.
I think that's an amazing endpoint, and it's something that people they can't necessarily put their finger on. That's what's missing from their feeling of self, but they start getting one skin cancer and another, and then they've had 3 in a year, and they're scarring the recovery and the time off work, and they just feel like they're on ice. Yeah, they're running on ice, and suddenly the things that they took for granted, their skin, which they took for granted, is letting them down.
That's right.
So to try and wind that back and try and give them a feeling of control again,
it's huge.
That's immeasurably beneficial. Yeah.
It is. And I always say to them, look, it seems like a lot at the beginning, and often you get one, and we know that if that cancer is going to come back, it's more likely to come back within the first 5 years. We know that you're most likely to get a second cancer again within that 5 years. So it will feel like it gets worse before it gets better. It's almost like, can almost feel like a bit of a domino effect, which can be really overwhelming, like you said. That
lag.
Yeah, it is. It's all of a sudden you just kind of tip over.
Once again, that close monitoring, and you're picking the lag cancers earlier, so the treatments mightn't be as aggressive.
Exactly.
But then you get over that hump, and you turn things around.
It's fantastic, and you can kind of plateau. If you're doing that, you've gone through this kind of roller coaster of emotion and surgery, and then afterwards, once you've gained control, you're doing all the right preventative things, you're doing early detection, we're optimizing your skin. Then it evens out, and then we have these great consults where we say, found nothing, or there's only one thing that we need to biopsy versus maybe there were 5 and now there's only 1. Or maybe, we can space out your follow-up now. That I don't need to see you anymore every 3 months. We can go to 6 months, or I don't need to see you every 6 months. We can go to 8 or go to 12. And I think that's a great turning point. And people really then feel, okay, this is, there's a way out of this. 'Cause I think sometimes, especially if you have big, large and complex surgery, you can just feel like, you've got no control. There's no way out. But there is.
The things you took for granted have been taken away from you, and you just don't know. You're just a leaf in the wind. You don't know where you're going to land. You don't know how it's going to turn out. And giving that control back and getting their feet back on the ground and just giving them a pathway, that makes such a big difference.
It does. It's very satisfying.
Neve, what I'd say on a personal level is I love working with you. I think you're an incredible dermatologist. You're an incredible Mohs surgeon. You do a lot of your own reconstructive work, and that's beautiful work. The cases that you do send me, they're always challenging, and I know to expect challenging cases because you've dealt with the ones that you're comfortable dealing with. But that ability to work in unison with a like-minded practitioner to achieve the best possible results for patients, which is at the front and centre of both of our practices and our practice philosophies. It's a wonderful synergy, and it's a lovely thing to share with you. Neve, thank you so much for coming in today and sharing your time with me and the listeners. What are your 3 key takeaway points for the listeners today?
I think the 3 key takeaway points are to get checked, make sure you're getting checked, and to focus on prevention and early detection. I think that's really, really critical. This is going to end up being 4 actually, but if in doubt, get a second opinion and get a biopsy if something's not healing or easily bleeding. And then the last one is, of course, look, if it comes to surgery, in the right hands, you can get a fantastic outcome. So it's just about making sure that don't avoid it, because if you go to the right people, you can get a great result.
Excellent takeaway points, Neve. Once again, thank you so much for your time. Really appreciated the chat. I think it'll be very informative for all those who tune in. This was Patient Matters, and today's topic was Mohs, melanoma and plastic surgery. Thank you for tuning in. Goodbye for now. This episode was researched, produced and directed by Michael Hennessy. Filming, recording and post-production by Wombat. Photography and lighting by Francisca Rauenhoff. Hair and makeup by JJ Rauenhoff. If you are thinking about undergoing plastic surgery, please make sure to consult with a qualified plastic surgeon. You can listen to more Patient Matter episodes on YouTube or follow the links on the Dr. JSK website. Thank you again for tuning in. I'm your host, Dr. James Southwell Keeley.